Hello, everyone. I think we are going to start with the second part of our session. So hopefully everyone had an opportunity to stretch their legs and grab some refreshment. Just to reassure people that this session is being recorded, the slides and the recording will be uploaded onto the NCISH website. So I'm really pleased to be introducing our next speaker before we break for the panel discussion. So Nav Kapur is a professor of psychiatry and population health at the University of Manchester. Many people will also be aware that Nav has led on a number of NICE committees. So most recently, the self-harm guidelines. I'm sure many people will have seen those guidelines, particularly the emphasis on moving away from the use of risk assessment tools. And Nav has also been awarded so many national and international awards for his suicide research. So thank you, Nav, and over to you.
Oh, thanks very much indeed, Pratibha. Thanks, Ian. Thanks, Lewis. Thank you to all of you for coming today. We've got people from as far afield as India and Australia. Last year, what we did for the first time was we presented some of the research findings from the wider centre in which the confidential inquiry sits. And we got some lovely feedback, so we've decided to do it again. Over the next 15 minutes or so, I'll be covering a few of the papers. It's been a really busy year for our research team. So these are very, very kind of selected highlights, really, focused on mental health, patient safety, primary care, and societal determinants and solutions. So over the past kind of 5 years, most of our kind of practical work focused on mental health, patient safety. Quite a lot of that has been done through a National Institute of Health Research funded Patient Safety Research Centre. And that's the only patient safety research centre in the UK that has mental health as a specific theme, a specific theme and focus. So I'm going to tell you about a couple of projects that we've carried out as part of that. The first is to do with family involvement. We've been talking at the inquiry about family involvement for quite a number of years, and this study is really looking at how that works practically, and was a qualitative and ethnographic study focused on crisis resolution home treatment teams, led by Louise Gorman and Donna Littlewood, who are there in the corner. And what an ethnographic study is, it means that actually our researchers went in and observed the teams, as well as undertaking some more traditional qualitative work. What did they find? I mean, some things that you might have predicted, really. So thinking about how family involvement can help. So it's not just about an information sharing, providing contextual information function. It's also about active helping keeping the person safe. Of course, sometimes there are challenges in involving families when delivering home-based treatment and other mental health treatments. Confidentiality, having the space to disclose, but also recognizing that family involvement, whilst generally very, very helpful, may not be helpful for every single service user and patient. And perhaps most kind of importantly, thinking about how we promote more effective family involvement. I think we do need to do better in mental health services. Some of that is about communication, some of that's about information giving, some of it's about how we organise our services, so offering flexible appointments. And of course, another aspect is about how we train our staff. So that's family involvement. Last year, I told you about some of Leah Quinn-Liven's studies looking at psychosocial assessment following self-harm. In the last 12 months, she's published a couple of papers on aftercare for self-harm, particularly accessing talking treatments, psychological treatments after self-harm, which we know are a good thing to do. They're evidence-based, and yet very few people get them after self-harm. So two studies here. One is, if you like, asking staff views, so liaison psychiatrists' views, liaison psychiatrists and nurses' views on psychological therapies and how we optimise access. but also patient use. So an interview study of clinicians, a survey of patients about how we can give people better access to talking treatments after self-harm. So here's a summary of some of the staff views. So there's a recognition there that multidisciplinary teams provide a kind of diverse skill mix, which might mean that you get better access to therapies, a diversity of perspectives. There's a recognition there that good access to aftercare begins with good assessment, so having a therapeutic assessment in the first place. There are also some kind of structural ways of increasing access, and this will come up again later, so integrated services, but actually having the psychological therapies available, having the staff available to provide those. And then some rather interesting kind of inside knowledge ones. So the fact that, you know, staff needed kind of inside knowledge to get access to psychological therapy. So crafting referral letters in the right way so that referrals are accepted. When referrals are bounced, you know, someone saying they don't meet the criteria, probing boundaries and really being a champion for patients, sometimes having to pull a kind of seniority or a kind of consultant card to help get patients the care they need, but also building relationships with other teams so that, you know, there's this kind of cross-referral joint working. Now, staff use, what about patient use? In many ways, kind of complementary. How do we increase access to talking treatments? There's something about staff, so staff who are compassionate, staff who do assessments and undertake aftercare in a collaborative way, training, continuity of care. Things about kind of information, communication can help improve access to psychological therapies, but also having the resources in place, the kind of structural points again, having the resources in place, having timely access to them, and having a choice as well. That's come up in self-harm, has come up also in relation to depression, having a choice of interventions available. So that's patient safety, a couple of the studies in our patient safety centre. I want to talk next about primary care, which in many senses I think is one of the last frontiers of kind of suicide prevention. It's something I think we've neglected to date a little bit, the role of primary care in suicide prevention, but a couple of things talking about kind of primary care. As Pratibha mentioned, you know, I do lots of kind of guideline work, perhaps too much guideline work over the years, but lots of guidelines came out in the last 12 months. The depression guideline after 7 years of development, and the self-harm guideline, which took slightly less time. And primary care features prominently in both of those guidelines. But one of the things I've grappled with over many years is how we take guidelines and make sure they don't just sit on a shelf somewhere, and how we implement them. So this is a really interesting bit of work done by Jess Leather, an interview study focusing on the old self-harm guidelines, so the 2011 guidelines, thinking about what helps and hinders implementation of guidelines. So this is a slide that tells you all you need to know about guideline implementation in primary care. But I suppose what I want you to look at is, you know, there's some things that enable guideline implementation. So training helps, skilled kind of communication and communication skills helps. IT solutions can kind of help. So, you know, GPs getting screen alerts when they're seeing particular patients that, you know, are informed by the guideline, that can help. And also the fact that guidelines themselves might provide a bit of confidence and reassurance, you know, that can help in itself implement guidelines. But of course, there are lots of barriers as well. You know, time pressures for GPs, that's come up in a number of domains. You know, this lack of resources, so the lack of the structural resources in order to refer people on, I think is a barrier. And this one was difficult to read, but I took it on the chin that guideline content sometimes when we do guidelines that can perceive to be kind of rather vague and unrealistic. So we've got to make sure that our guidelines are focused and deliverable. But some of the things that could improve guideline implementation. Fast forwarding now to the 2022 guideline. This is Faraz Mughals editorial about, well, what does that mean for primary care? I suppose, it's an opportunity to intervene. Many people have seen their general practitioners prior to suicide and self-harm, so there's an opportunity there. We're not trying to turn everyone in primary care into mental health specialists, but given how common self-harm is, GPs should be able to know how to do a basic assessment and when to refer. The importance again of kind of continuity and collaborative decision-making in management. GPs and indeed pharmacists have a specific role in relation to safer prescribing for people at risk of hurting themselves for obvious reasons. And again, self-harm doesn't work in isolation. We need to have aftercare, specialist aftercare that's accessible. So it's not just the offering primary care, it's also mental health services that work around that. That was self-harm in primary care. This is suicide now in primary care. And a couple of years ago, I told you about our suicide in middle-aged men report at this conference. Here's one of the academic papers, again led by Faraz, where we focused on people who'd recently seen their GP. So you'll remember in that report, one of the surprising findings is 90% of middle-aged men who died by suicide had seen some kind of health or social care or helping agency prior to death. And this study focused on that, a big proportion of men, 43% of men saw their GP within 3 months of dying by suicide. And many of them, only over half of them, had presented with a mental health problem. And that group were more likely to have been prescribed psychiatric drugs, but also other comorbidities. So it wasn't all about mental health, physical illness, work-related stress. And I think the point here is, again, it's about the systems. We need better systems of care. It's not about trying to pick the person who's at particularly high risk. You'll know we talk about that extensively in previous reports and in this report. It's about better systems and making every single contact in primary care and elsewhere count. Talked a bit about mental health patient safety, talked a little bit about primary care. The last thing I want to very quickly cover are the social determinants and solutions. Inequalities are a major cause, I think, of self-harm and suicidal behaviour. Helen will be talking about this in the panel. And this is a study now at self-harm. It's from the multi-centre study of self-harm that we collaborate with colleagues in Oxford and Derby and this study led by Galit Galof. And what this shows is where people live according to deprivation and the proportion of overall self-harm presentation. So these are quintiles. So what you would expect is that 20% of individuals would come from each quintile. Instead, what you find, which won't surprise you, is people who live in the most deprived areas are overrepresented. So this idea that deprivation is a cause of mental ill health, a cause of suicidal behaviour. And these groups have specific needs, so they're more likely to be men, more likely to have a history of previous self-harm or mental illness, more likely to be unemployed. And some previous studies have also shown that they're less likely to get access to care as well. So there's this combined thing of increased risk but reduced access to care. Another group that's hardly been out of the news over the past 12 or longer months are people who have migrated to the UK, particularly people who are seeking asylum, seeking leave to stay. This is I think, really important study led by Sue Guan based on inquiry data. And just taking a bit of that study, focusing on the people, who are seeking permission to stay. So many of this group would be, labelled as so-called kind of asylum seekers. It's very difficult to get good denominator data, but it does look like suicide rates are higher in that group. But they're also a group with who are more likely to be homeless, more likely to be from a non-white background, and have experienced many kind of problems compared with other patients who've died by suicide, so legal, financial, and health problems. And there's also a kind of clinical aspect to this as well. So they're more likely to have severe mental illness such as schizophrenia and delusional disorders than other patients. So a picture really of, you know, a group of people, a group of patients with very complex needs and possibly higher rates of suicide. The other thing I think that all of us working in mental health are worried about, been mentioned already, is a kind of potential impact of a recession or you know, period of economic adversity. So a group of, this is international researchers now led by my friend Mark Signor in Toronto, published this just last week actually, thinking about the effects of economic downturns on suicide and suicidal behaviour. Now, what economists will tell you is no two recessions, no two periods of economic adversity are the same. They're kind of subtly different. I think that's absolutely right. But we do actually have, I think, a very useful evidence base about some of the kinds of things that might help mitigate the risks of economic adversity. So this is a very busy slide, but I've only put it up because of the pretty colours. So there's some stuff there around data and research. So we need to know what's going on, particularly kind of real-time monitoring if we're thinking about the effects of economic adversity. Thinking about the impacts on health and social care. So it's not just about resourcing of health and social care during periods of adversity, but it's also about training frontline workers to spot the signs of financial related stress, ensuring that they're able to signpost people. The role of the media as kind of mentioned this in his talk as well, but specifically in relation to recessions and downturns, you know, avoiding sensationalized reporting of the possible ill effects of a downturn. So, you know, avoiding, you know, possible kind of, you know, kindling or imitative suicide, avoiding drawing simplistic connections, and promoting help seeking. I think the media have a big role. Public health, disseminating messages around well-being, but also thinking about harm reduction as well. Alcohol price controls are really interesting kind of intervention that have effects in a number of domains, not just mental health. Thinking about, you know, how you might increase social cohesion. We saw some of that during the pandemic, in fact. Probably the most important mitigation factors are the economic ones. You know, thinking about austerity as a response to economic adversity actually worsens suicidal behaviour, is a risk factor, whereas promoting labour market reform, making sure people have the assistance they need, again we saw some of that during the pandemic, can be protective. But I'm sure we'll pick some of this up in the panel discussion. Lastly, machine learning and AI, that's everywhere. Ian talked about it in terms of algorithms and social media, but there's quite a lot of interest in it as a potential intervention. I think, in my view, it slightly overpromises. This is a review that Olivia Kirtley in Belgium led on, that we were involved in. What's the bottom line? The bottom line is actually some of the research is less than ideal. Quite a lot of it's focusing on health records, but the clinical practicalities of introducing this stuff is often ignored. The other thing that you've heard me bang on about for many years is the prediction element of risk assessment. It's the same for machine learning. You're not going to be able to predict, even with supercomputers, who dies, who sadly dies by suicide and who doesn't. Prediction of statistically rare outcomes is impossible. So I don't think that's a fruitful use of machine learning, but I think it could be helpful for clinical decision support and particularly kind of training. We make the point in the paper that, you know, a lot of this stuff overpromises. We make the point in the review about data quality. A lot of the data quality is poor. Transparency of these models, you just get this machine learning model that churns out an answer, you don't know how it's got there, so that's really important. And the ethics of a lot of this. So what would happen if machine learning got it wrong in mental health, got it wrong in suicide prevention? What about other models that seem to systematically disadvantage some people? So, for example, people from ethnic minority groups. And a lot of these models have been developed in high-income countries, so we don't even know if they'd work in low and middle-income countries. And another problem, I think, is the lack of evidence, both around the machine learning themselves, but also the interventions around it. So if you've got machine learning as a kind of, adjunct to care, you've got to have the aftercare in place in which to refer people onto. So have a read of those. On all these slides, you've got links. So the slides will be available. You can click on the link, take you straight to the paper. So I've talked a little bit about mental health patient safety, the work of our patient safety translational research centre, a little bit about primary care as I think one of the really important frontiers of suicide prevention. And then I've talked a little about societal determinants and solutions, and something I think we have to keep a continued eye on. Quick summary: family involvement, access to aftercare, really important elements of safety. Primary care, key setting. Guidelines can be helpful, but there are some barriers, but also enablers to implementation. We need better systems of care, I think, in primary care, particularly for vulnerable groups such as middle-aged men, and the structure around primary care, so the joint working between primary and secondary care. Inequalities, absolutely vital, really important. I've mentioned people who've migrated and who are seeking permission to stay as a particularly important group. Economic stress, we'll talk a bit about that, but the effects can be mitigated. And AI isn't the answer to everything, but might be helpful. And the last thing we'd like to do is just acknowledge all the people at the Centre for Mental Health and Safety who have contributed to this work. We've not managed to photograph all of them. Some of them are kind of a bit photo shy, I'm afraid, but just a tribute to them and all their hard work. Thank you very much indeed.